Just to remind you what the NIHR is all about, the key thing I wanted to remind you there is, and so this is one of the differences between what Chris was talking about before and what we're doing. Research is a really important thing. What we're here to do is to help you develop the evidence that's going to convince someone in the healthcare system to use your intervention. Along the way, clearly, wealth is important because you can't get this stuff sustainably to patients without some kind of vehicle, even if it's a not-for-profit of some description. But research is the key thing. The bit I'm mostly going to talk about, NIHR is a whole system. The HRCs are part of that. They're in the blue box. They only get a little bit of that money in the blue box. The bit I want to talk about mainly is in the red segment there, which is what research programs. That's the things you write applications for. Before I get into the funding, I just wanted to say NIHR as a whole system, there's an awful lot more about NIHR that you may not know, and especially if you're a small company, access to all this stuff is free. If you're already engaged with the HRC or the MIC, you will probably know some of this stuff, but, oh, that's interesting, what's done to my slides? Anyway, so research delivery, clinical research network, it seems to be it's the time of year, but everybody's changing the names of everything. So on the 1st of April, it's going to be called the Research Delivery Network. It won't be CRN anymore. So if you've got to do clinical trials in the NHS, these are the guys that can help you. There's lots of useful stuff that they can do for you, including finding sites and people that want to collaborate with you. And that's a free service to you as a small company. Expertise, we fund, well, considerably in excess of 25,000 people across the NIHR. We have a process that, well, we're now calling it Life Science Industry Information Service, but there's an expert partnering service as part of that, which can connect you to someone. If you tell us what you're interested in, what sort of connection you need, 2 weeks later, you can get a list of people that might be interested in talking to you. Some of those may well be in the HRCs in that relevance. So we've had a team of people that help with that. We've got samples and data. We've been going for about 17 or 18 years. There's a lot of data and quite a lot of samples around, and we're well connected into the wider ecosystem. We do have a few bits of bricks and mortar, but we tend not to fund bricks and mortar too much in NIHR. I'm going to talk about funding. So where do we fund? You probably know this already. We pick up where Philippa leads off, more or less, in terms of research council funding. If you think about it in terms of the stages of development, it's the translation and clinical piece. When it gets to being adopted, that then becomes someone else's job, which is probably the Health Innovation Network and or bits of NHS England, in principle. We are starting to use the word adoption in the NIHR, which we never were allowed to do before, which is quite encouraging. So hopefully watch out for some things that we might want to do in that space. I know TRL are not necessarily the way you want to think about things. You can think about it in those contexts as well. And the problem with TRLs is there are loads of different definitions. And do you go to 9, do you go to 10? On this scale, we start funding at 3, thereabouts, or above, and we get to 9. Once it gets actually on the market, then we're not going to fund it. Just to make it more complicated, we've got 11 different funding programs. That's excluding the ones we're doing globally through global official development assistance. The ones that are highlighted or emphasized are ones that may be mostly relevant for some form of research to do with medtech. Clearly, I'm not going to talk about all of those today. I'm just going to talk about i4i, because i4i is the funding program for medtech. What do we mean by that? We mean medical devices, in vitro diagnostics, and medical or digital health technologies. Digital health technologies in Tier C on the NICE evidence framework, which means they are patient-facing. We're not going to fund you to do research in designing a system to measure how many empty beds you've got in your hospital or manage the system. We're not going to fund you to develop an app which you can put in the App Store and a patient or a public person can download and just manage their own health. We're going to do it when it much more to do with connecting that person to the system. So it's going to be patient-facing. If it's a medical device, software as a medical device, it will be Tier C. Because NICE changed their definitions a little while ago, Tier C now includes some things which are not medical devices. For all of those things, there's a kind of starting position you need to be in. One of that is some kind of proof of concept. You're going to need to come and talk to me about what proof of concept means, because I can't give you a nice, clean, simple definition, because it might depend on what your technology is doing. It could be partly that you've already made a prototype and you have something in your hand that does what you want it to do, at least in crude form. It might be that you've got a piece of that's the key piece, and the rest of it is, we know that if we can do this, there's literature evidence that says that's beneficial. That can be a perfectly good proof of concept. Come and talk to me about that if you need to do that. We are very interested, even if you're at the beginning of that journey, in how this is going to get to the patient. So whilst it says a clear pathway to adoption and commercialization, you probably don't know the answer to that. But we're expecting you to start thinking about it, and it's something that you can build into the cost of your award. As of August last year, we're no longer restricted to funding in England, so we can fund across the whole UK. In fact, I was in Northern Ireland earlier this week talking to some of the innovators over there about how to get some of our funding. So a bit more competition, I'm afraid. We have 3 streams of funding. Most of our money goes into what we call product development awards, which kind of does what it says on the tin. If anyone had an i4i award? Well, there's a few. Some of you haven't had one, but may have applied and didn't get one. I won't ask that question. Some of you know a bit more about i4i. We used to have something called Challenge. As of the next call, Challenge and PDA have been rolled into one. So we now have a continuous process effectively from that TRL3 to right through to adoption, which means there are no kind of unnecessary gaps and barriers in the process. So anywhere in that process you can apply. So that means right from that early prototype and minimum viable product and some early sort of first-in-human studies right through to post-regulatory evidence generation and implementation studies. One of the key things about that is there's no upper limit to the funding that you can get. What you do is you tell us what you're doing, you tell us how much it's going to cost. Clearly there's a value for money assessment criterion, but that's an important thing. On average, just so you know, our average awards currently are running at about 1.1 million for those over a 3-year period. We vary between about 400K, probably about 2.5 million in our current portfolio. Biggest award we've ever made is 4 million. That was a very specific winner-takes-all challenge around mental health. Has to be collaborative. And lead organisation can be a university, NHS trust, or an SME. So that's worth knowing. And if you're an SME, you get 100% of your funding. Come and talk to me about how that works. I want to say, just one thing I will say, it's not a grant. So NIHR doesn't give grants, it gives awards. That means there's a contract, and that means there's milestones and all that kind of thing. So that's the part of the way it works. i4i Connect, up to 150K, 6 to 12 months. You need to be an SME to be the lead organisation. You can apply just on your own. If you do that at the beginning, we will expect you probably by the end of that award to have started to build your team and your collaborations and connections for the next step of the journey. But you can obviously have collaborative partners as well. Fast awards, which is probably one of the things that's got us a lot more visibility in the funding space. Up to 50K, 15 to 50K, 3 to 6 months, basically to fill one single piece of evidence that's missing, or do a particular piece of work, such as something to do with a regulatory package, for example, doing some of that clinical validation that we were hearing about a little bit earlier on. That can be covered by something one of the FAST awards. And again, any of the types of institutions can apply to that. Anything you need to do as part of that development of your technology can be funded. So very often, by the time you come to us, mostly the technology is the easy bit. The bits that are going to trip you up, the bits that are going to cause more problem, is all the other stuff. All of that the relevant things related to that, you can cost into your award. So things to do with health economics, absolutely. If you haven't got some kind of health economics or a plan to build the model that you're going to need to populate later when you get more data, you're probably not going to get funded. Things about IP protection, regulatory, building your QMS if you need to do that, hiring in a regulatory consultant if you need to do that. All of those things can be costed into the price of the award. There are a few things we don't fund just because NIHR has a policy, or the Department of Health has a policy for NIHR. So we don't do things to do with animals or animal tissues or stem cells. Basic research, that's Research Council's purview. Scale-up manufacture, by which I mean we're not going to make 200 or 300 of your devices so that you can do a big clinical trial, because that's not research, that's just manufacturing. We can pay and we can do the design for manufacture, make the first 20 or 30 for that first in human study. That's absolutely fine. But if you're a company, don't come to us to ask us to make 300 because you won't get funded for that. TRA and TB, digital health technologies. Professional training, if you're an academic institution, what that means is we can't pay your PhD or MSc academic fees. We can pay for the person's time, but we can't pay for the fees. I don't want to go through the whole process. Suffice to say, pretty much all of our application processes are two-stage. It's not necessarily a very short process, but for product development, it's about 7 months roughly from beginning to end, well, from the deadline for stage 1. Deciding whether you got shortlisted, knowing whether you've been shortlisted is about 2 months, so it's not such a big deal. Second stage is a little bit more intensive. The application's a bit bigger. But the success rate at second stage is 50%. So if you get shortlisted, and that probably isn't going to change, even though we're getting more applications, we're working towards on having roughly about a 50% success rate at stage 2. You will be asked to come and present. You get 10 minutes to present. It will be absolutely 10 minutes, and then you get grilled by the committee for about 15 minutes, and then they'll make a decision. Connect, similarly a two-stage process, except the first stage is really like your 5-minute pitch on a piece of paper. Again, shortlisting, it's a slightly faster process. Again, 50% roughly for the second stage. Overall rates are not too bad. Fast so far, this is a single-stage process. It's very quick. There's 3 boxes of information that we want to know, what you're going to do. We're actually close to 30% success so far, which is quite good. We funded a lot and spent quite a lot of money as a program. I haven't got time to talk to you about all the things that you need to think about in terms of what makes a good application, but there are some people who can help you with that. Research Support Service, I don't know, actually there isn't a hub here, is there? But I'm sure there are people in Leeds who are working with the Research Support Service. Come and talk to the HRCs because they can help you. They know us pretty well and supported quite a lot of applicants to i4i. 1 or 2 examples, covering everything really from bits of kit. If you're doing diagnostics, nearly all of our diagnostic applications, not quite, but most of them currently are how to make something that's point-of-care device, some sort of test that's point-of-care. That might be a completely new test that's now or it may well be something that's been sitting in a big box in the laboratory, which is now going to be point-of-care and at use. Through to software for children's mental health. Thing you want to know is about when's the next call. The next call opens on the 10th of April. So if you haven't been starting to think about it, start thinking about it pretty quick. PDA calls come around twice a year. So every 6 months there'll be a new one. They'll come around quite frequently. The next Connect call, at the moment we're only managing to run 1 Connect call a year. The next one's not till next January. We've just closed that. I haven't got a fast date yet for the next fast call. Kind of ironic, really, for a program called FAST. We are in the discussions with the department about how much money they're going to let us spend on FAST, or make us spend, actually, because it's quite hard work running a FAST course at 50k, lots of applications. It will be themed. I can't tell you what the theme is, because that's part of the negotiation, but hopefully fairly soon there will be something up there, so keep an eye out for that.
Thank you, Ian.